Yeah, and so now it's a little bit trickier of a question on selecting bridging therapy because we have patients that are early line CAR T, they're late line. In the beginning, it was much more difficult because most of the late line patients don't have a lot of good bridging options. And so those patients that are late line, we're now using a lot more bispecifics to try to cool down their myeloma, get them in better cytoreduction before proceeding with CAR T. Earlier line patients at least have the option of more cytoreduction standard options. For example, a lot of the patients that are second or third line may not have had carfilzomib or pomalidomide, and those sorts of combinations can be very effective for those patients. If at all possible, we're trying to start the bispecific bridging after the collection so that we don't impede or impair the fitness of the T cells that we're collecting in the product whenever possible. And we don't really even have a lot of good data yet on even using it as bridging after collection, but at least there we're not worried about what's collected in the product. Yeah, I think as long as it's a brief duration, 1 or 2 cycles, we usually wouldn't run the risk of having them become refractory or mutating their receptor. But in general, I've been using a different target than the CAR T, for example, GPRC5D, so that we don't run the risk of downregulating BCMA.